Good afternoon. I'm Barbara McLean, and I'm here to present to you the third component of the rhythms of the cardiac system and file number 5 in the cardiology overview for Rise Up Critical Care, a short-time critical care course designed to assist those expert nurses in raising their skills for caring for critically ill patients. And so to begin, we want to remind ourselves that rhythms are described either as fast or slow, and we like to make sure that every P has a QRS, looking at P to P interval and R to R interval, and that every PR interval is constant, and that the QRS width is less than 0.10 and at the max less than 0.12. Rhythms are described as narrow QRS tachycardia, wide QRS tachycardia, narrow QRS bradycardia, and wide QRS bradycardia. We've discussed that a few times and we'll be discussing it again. So salient points so far. Persistent tachycardia is always a warning sign. Pay attention to it. It's a signal that something's wrong with the patient. He's in pain, he's agitated, he might have a high fever, or his tissues are hypoxic. So pay a lot of attention to that and make sure you're evaluating it. A rapid heart rate also limits ventricular filling, and because it limits filling, it will therefore limit the amount of volume ejected by each heartbeat. Remember, persistent tachycardia is always a cause for concern. Bradycardia with hypotension is always abnormal. There are two major groups of electrical cells, the pacemaker tree and the myocardial tree. Remember, the pacemaker tree is primary pacemaker cells. If there's failure of a higher pacemaker, a lower one will fire. That is known as an escape rhythm. Escape junctional, escape ventricular, or idiojunctional, idioventricular. Non-pacemaker cells can also take over electrical control of the heart. He who reaches threshold first is in charge. Atrial cells are potassium and calcium dependent for depolarization, and ventricular cells are potassium and sodium dependent for depolarization. Now, the atrial tachydysrhythmias respond to beta block, potassium and calcium channel antagonists, and ventricular tachydysrhythmias respond to potassium and sodium channel antagonists. So I do want to make sure we appreciate sodium and potassium for ventricular cells, despite my little typo, and for us to remember that we're talking about electrical activity, not mechanical. Very good. So the next group of salient points so far are the heart block groups. First degree and second degree Mobitz type 1 block usually are in conjunction with disease or ischemia in the AV junction. Second degree Mobitz type 2 and third degree heart block usually occur at the His bundle or below. First degree block is associated with increased risk for atrial fib, may require a pacemaker implantation, and it correlates to all-cause mortality. Sometimes first degree AV block is the only sign you have of right coronary artery occlusion. Second degree heart block, if it is noticed with 2 or more non-conducted PACs before each QRS, is actually a sign for pacemaker. That pacemaker is indicated by the presence of second degree or third degree AV block, which of course third degree is complete heart block, and reversible signs of complete heart block include medications and Lyme disease. So key points to remember. Heart blocks above the His bundle tend to be more stable. Heart blocks below the His bundle tend to be more unstable and will frequently require consideration for pacemakers. Okay, so let's begin. We want to remember that instability is heralded by hypotension and hypoperfusion. You can have hypoperfusion without hypotension, which is why critical care nurses have to pay so much attention. By alteration in the mental status, because the blood flow gets redirected away from the brain and now we have a change in mental status. By chest pressure or chest pain, by coronary ischemia, shortness of breath, and evidence of pulmonary edema. So we always want to remind ourselves, if our patient has tachycardia and they have hypotension, that's a normal relationship. It doesn't mean the situation is normal, it just means hypotension should always be accompanied by tachycardia. And hyperthermia should also be accompanied by tachycardia unless you are using hypothermic measures. Precedex, which is dexmedetomidine, and hypothermia may cause bradycardia. Okay, so what we want to just remind ourselves at this point is to revisit the impulse that starts at the sinus node, actually translates through the intra-atrial conduction pathways, where it's gathered by the AV junction, down into the common bundle of His, and then delivered into the right bundle branch and the two divisions of the left bundle branch, one that's forward, anterior, and one that's behind, posterior. So, SA node, remember, is in charge of the heart. Normal firing rate, 60 to 100 beats per minute. Depolarization actually is what stimulates the release of calcium, and calcium is used for myocardial contraction. So depolarization first, contraction second. So from the SA node, the depolarization curve into the atria is called the P wave. That then correlates with an influx of calcium into the cell, which then allows for atrial contraction. Then we go through those internodal paths. That's what you're seeing with the shape and the form of the P wave, is the electrical impulse as it exits the sinus node and distributes throughout the right and left atria, which are depolarized typically at the same time except in hypertrophied states. Then into the Bachmann's bundle, which is a specialized group of intraatrial fibers found in the left atrium, and it conducts that electrical activity from the sinus node into the left atria, and that of course is what allows for the right and left atria to be depolarized synchronously. Then from the Bachmann's bundle into the AV node, that lovely AV node that delays the transfer of impulse to allow time for our atria to contract and squeeze volume down into the ventricle. So there's a delay time in the atria, that's called the PR segment. It allows for more complete filling of our ventricles, and it really is the only pathway of electrical impulses to the AV junction and down into the ventricles. We love our AV junction. That's what holds that impulse for a longer period of time to allow time for the ventricles to fill optimally. Remember that the AV junction is our secondary pacemaker, meaning if the sinus node fails, the junction will reach threshold first and take over depolarization of the heart. The bundle of His, which is a very specialized pathway, it has rapid channel and slow channel depolarization, and it lies at the top of the intraventricular septum, often referred to as the common bundle, pre-right and left bundle branch blocks. It has the ability to initiate a firing rate to escape from death when the sinus node has failed. The firing rate of the common bundle of His is somewhere between 40 to 60 beats per minute. And because it's a supraventricular, the depolarization down into the ventricles will appear exactly the same as if the impulse had come from the sinus node, just a little bit slower. The bundle branches, remember, we have the right bundle and the left bundle, which has two divisions, and that's where we electrically conduct the activity out into the Purkinje network, which then causes almost simultaneous depolarization of the right and left ventricles. Now we want to remind ourselves that something interferes with this would be bundle branch block. Something else that may interfere will be ventricular hypertrophy. Not for today's lecture, but we'll talk about ventricular hypertrophy and what happens to your EKG in those scenarios. So, always remind ourselves the final point is the Purkinje network. Those are the fibers that are spread throughout the ventricular muscle mass, carrying impulses directly to the cell, opening those channels, stimulating the opening of those channels. But the Purkinje fiber as the third pacemaker, what we want to remember is those Purkinje fibers fire at a rate of 20 to 40 beats per minute. Now that gives us a rhythm called the idioventricular rhythm, or ventricular escape, which means you never want to suppress it because it's the only thing that's keeping your patient alive. Okay, so we want to review very quickly lead placement across the precordium. So that would be your brown electrode on your 5-lead EKG, and if you're having a 12-lead EKG, each position has its own electrode. So fourth intercostal space to the right side of the sternum, my right, not yours. The right side of the sternum, fourth intercostal space, V1. To the left side of the sternum, fourth intercostal space, V2. To the fifth intercostal space, midclavicular line, V4, and the fifth intercostal space, midclavicular line, V6. V3 is midway between V2 and V4. V5 is midway between V4 and V6. When you place a Brown electrode, don't let me ever see that you put it on the sternum. That's incorrect. Find the accurate chest position and place your Brown electrode there. Now, the reason we have to talk about chest leads is because we're getting ready to talk about bundle branch block. And the way for us to fully diagnose bundle branch block will be using a V1 and a V6. But if you can only look at one chest lead, you'll look at V1 and you'll use lead 2 to mimic V6. So V1 and lead 2. We're looking at the heart from two directly opposite sides. The right side and the left side. The right side and the left side. So that I can look at the mirror image of electrical conduction in the heart. More about that later, but it's very important. What I see on one side, I should see the exact opposite on the other. And that's what I always look at when I see an EKG. So what we want to think about is if we have functional bundles that rapidly conduct depolarization into the right side of the heart and the left side of the heart, we're just going to see that both ventricles depolarize at the same time and we'll get one sturdy R wave. But if one of our branches is blocked, we will have dysynchronous depolarization, dysynchronous contraction, and we're going to see it on the EKG, the evidence that one ventricle is electrically activated first and the second ventricle is electrically activated second. That gives us what we traditionally call the R with the second R, also known as R prime. R to R. First R is the ventricle with the functional bundle being depolarized. Second R is the ventricle with the blocked current depolarized. Because the heart is always going to depolarize, but it just does it in a different way. Actually, cell by cell by cell, rather than activated by the network. So that's really important because we're seeing two different ventricular depolarizations. Now, if those two depolarizations are going to the right, you have a right bundle branch block. If those two different depolarizations are going to the left, you have a left bundle branch block. Now, we'd like it to be that easy, but it's really not. That's just giving us a basic framework from which to jump off in the evaluation of our patient. So now we're going to use the term William Morrow. Probably nobody even knows what William Morrow is, but if you watched Mad Men, you might recall that William Morrow was a big advertising agency during the 1950s. None of you were born. Your parents probably weren't even born then, and that's okay. But why we say William Morrow is that with left bundle branch block, you will have a double down in V1. That's the right sided lead, seeing it go away, away, away. And a double up in V6. So William Morrow. William Morrow. Now, with a right bundle branch block, you'll have a double up in V1 because it's going to the right to depolarize the right bundle, and away from the left. So going to the right, away from the left. So that can help you. It's a very simple mnemonic. I'm not particularly fond of mnemonics, but I want you to understand bundle branch block simply, and then we're going to look at it more complexly. Okay, so bundle branch blocks. What we want to remember is the right and left bundle actually bifurcate off the bundle of His. One branch for each ventricle. Always important to remember that that left ventricle is a much bigger muscle, so it actually has two divisions, the one in the front, anterior, and the one behind, posterior. Now, what we look at when we look at our depolarization of our ventricle, which we commonly would call the QRS, is actually direction, meaning should go towards the left because the left ventricle is the bigger ventricle, and time. Now that's what's really important here, because when you have a ventricular conduction delay, it's going to take much more time for the ventricle to depolarize. So when there's a delay, that means that the width of your QRS is, ding, 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 yes, greater than 0.12. Now remember, we focused a lot on the width of the QRS. With bundle branch block, you'll be wider than 0.12. Now that's what happens with a complete bundle branch block, which is our focus for this class, a complete bundle branch block, not an incomplete. Okay, so those electrical patterns point to the side. If current is going to the left, if current's going, I don't even know my left, current's going to my other left, to the left side, that is the normal direction of current because the left ventricle is a large ventricle. But it takes more time than usual. So the width is greater than 0.12, but you'll be upright in your V6 or lead to lead, which are representing the left heart, and you'll be downwards in V1, which is representing the right heart. With a right bundle branch block, all current goes towards the right. That's abnormal. And that means in V1, you'll see a visualization of current coming towards the V1 lead. It will be upright, should never be upright, should always be downwards, because it should always go to the left. But now it's coming to the right because we have a right bundle branch block. That width will be wider than, ding, 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 0.12. Good. So that's a really important concept for us to remember. Now, why do we get a left bundle branch block? This never occurs naturally. You never have a left bundle branch block pattern naturally. It is associated, of course, with a big anterior myocardial infarction, with heart disease, congestive failure, a large heart, so hypertrophic, cardiomyopathy, weak heart muscle, a stiff ventricle, and when patients have built their ventricle into a much bigger muscle mass because of continuous ejection against a hypertensive state, a vasoconstricted state. It is never normal to have a left bundle branch block. Now, oftentimes we'll say a new onset left bundle branch block may mean that we've had a new myocardial infarction. That is some of the criteria. It's not an absolute criteria anymore, although if you looked at the Heart Association's website, they might include new left bundle branch block as an indicator of myocardial ischemia. We are going to appreciate that it's subtle to look at a left bundle branch block. In the side of the heart where you have the bundle branch that is not functional, current is going slowly, slowly to that side, and when you repolarize, you will have an inverted T wave only on the left side of the heart. So in left bundle branch block, we'll have an upright R. It will take more time than 0.12, and the T wave will be inverted. Those are simple rules of thumb that help us when we look at left bundle branch block. So taking a look at V1 versus V6. Now remember, you won't be able to look at V1 and V6 with a 5-lead cable, so you'll use lead 2. That's a modification, but really you want to make this diagnosis from a 12-lead EKG. Okay, so criteria for left bundle branch block. QRS must be wider than 0.12, and you have broad depolarization in lead 1, not V1, lead 1 and V6. Lead 1, positive electrode is on the left arm, and V6, your positive electrode is on the left side. So you're going to see the same kind of configuration in lead 1 and in V6. In V1, you have a wide deep QS. You have no R wave, just a wide deep QS. And in V6, you have the absence of what we consider physiologic Q waves. You just have a wide, time-consumptive upright, and you can see it right there. Okay, so left bundle branch block, wide QRS or S complex in V1 with a slick downstroke, and it takes time to get to the peak. And in V6, you maintain your R wave. It's maintained. It's always upright in V6 unless you've had an MI. And that R wave is wider than usual. So let's take a look at this, isolating V1 and V6. V1 and V6. So not lead 1, okay, V1 and V6. In V1, you have an extreme downwards, and in V6, you have a normal upright. But you can look at both of those and see that they are 0.12 or greater. Okay. In V1 and V2 and V3, maybe even in V4, you have a little S2 segment elevation, which is actually something that occurs when you have a left bundle branch block, as well as when you see left ventricular hypertrophy. So now look at V1, which is deep and down, and V6, which is small but upright, and both taking a long time. So now, looking at V6, you will also see that the T wave is inverted. It's in the opposite direction. T waves should be upright. They should always be upright. You might see them inverted in some leads normally, but in V6, it should never be downwards. So that tells us we have left bundle branch block. Okay, so taking a look at those waveforms and comparing them gives us lots of good information. So we want to remind ourselves of what that physiology is. Sorry about that. With a left bundle branch block, your septum depolarizes from the right side of the heart to the left side. So you lose sort of the visualization that you had on the other side of the heart of the right ventricular depolarization. The depolarization takes a long time because instead of rapidly down the Purkinje fiber network, it's cell by cell by cell. Because we're going to depolarize the left heart whether or not we have an electrical conduction pathway. So it's slow and wide. That lead in V6 is entirely upright. It's wide and it's abnormal. And in V1, you see all current going away from V1, promoting a wide QS wave. So now let's move to right bundle branch block. By the way, right bundle branch block often happens because the right bundle is refractory a longer period of time. Less oxygen delivery to the bundle, so with a high heart rate, you could actually be in a bundle branch block pattern. That's known as rate-related bundle branch block, and it is something we see quite frequently. So causes of right bundle branch block: myocardial infarction, most particularly left anterior descending disease, because the LAD is what supplies the right bundle. Also, viral or bacterial infection of the heart muscle, known as myocarditis, which is not uncommon in patients with COVID virus, so you might see a right bundle branch block in those patients. Patients who have pulmonary hypertension, pulmonary embolism, anything that increases right ventricular afterload that's obstructing outflow from the right ventricle can cause a right bundle branch block. But very concerning to us is that sometimes with a rapid atrial rate, a rapid supraventricular rate, it will be conducted down the common bundle, but the right bundle will not be able to accept the impulse. So it will be what we call an aberrant conducted rhythm, meaning SVT with a wide QRS response. So remember, if that occurs, rapid SVT conducted with the right bundle branch block pattern, check your leads, check your patient. If your patient has a pulse, you will cardiovert, and if they do not have a pulse, you will defibrillate. Doesn't matter if it's rapid SVT if they don't have a pulse. So the pulse helps us to make a difference in terms of diagnosis and a therapeutic intervention. Okay, so criteria for bundle branch block. QRS wider than 0.12 seconds. And in the V1 lead, which is, remember, a right-sided lead, all current going to the right. That's the wrong way. Even though the word is right, current going to the right is the wrong way. It should always direct to the left heart. So we have a big R wave in V1. Sometimes we see a little r and a second r, that's known as RSR prime. Sometimes people call that right rabbit ears, not me, I don't like that term. And most of the time patients don't actually present with RSR prime, meaning you have an R wave, a little wave that goes downwards, and then one that goes upwards, RSR prime. But we can see it's wide, and by the way, you can see that the T wave is inverted. Okay, so the summary for right bundle branch block, what we want to remind ourselves, right leads, especially V1, show an RSR complex with a very wide R wave taking greater than 0.12 seconds. Sometimes the S wave is just a notch. It doesn't even get to the baseline. And that's why sometimes we call that right rabbit ears. But lots of times that doesn't happen and it does not always occur. The left-sided lead, that means your lead 2 or your V6 lead and your lead 1 will show a Q, small r, and a deep S wave. So turned upside down or in the mirror image, it's exactly the opposite of what you saw in V1. Now, what are we going to do about bundle branch blocks? Well, first of all, we're going to try to figure out why you have a bundle branch block, and we're going to try to treat the cause. That's the main thing that we do with bundle branch blocks. Now, we might give you a pacemaker if you have first degree or second degree block with bundle branch block, because now you've got at least bivesicular block. So I want to restate that because I kind of stumbled on my word there. So if you have first degree or second degree block with a bundle branch block, that's really prodromal for complete heart block. It's a bivesicular block. It may give us some significant consideration. So we're going to consider implanting a pacemaker to prevent you from having complete heart block, or if we've seen evidence of complete heart block that comes and goes, or you have Mobus type 2 with 2 non-conducted Ps with no QRS, which is always prodromal for complete heart block. And when bundle branch block is associated with left ventricular failure and a reduction in left ventricular ejection fraction, we're going to consider a pacemaker for you. If you are unstable hemodynamically and you have bundle branch block, you're also going to get a pacemaker. So these are important cues for us because in the ECC or on the floor, you may not have the opportunity to drop a transvenous pacemaker, but you do have the opportunity to do transcutaneous pacing. So be aware of how your patient is presenting so you can be prepared if they decompensate. Okay, so now we just look at comparative analysis of normal. Normal V1, tiny r, and big S. Tiny r, big S. Normal V6, small q, big R. And you can see they are upside down from each other. They're exact replicas of the upside down electrical depolarization. Same thing is true with right bundle branch block, except now you have a return of current to the right. That's that RSR prime that you're seeing in that visual. And on the left side of the heart, you see a small q with an R. And what's so remarkable here is the deep, wide S wave. That S came after the R. Remember, just like the alphabet, find the R. In front of it, a downwards, that's a Q. Behind it, a downward, that's an S. That's the P, Q, R, S, and of course, ultimately, the T. Okay, so in left bundle branch block, you see an extreme downwards in V1. That's not that unusual, but it's wide and it has a little notch. That's unusual. And when I compare it to what I see in V6, it's all upright. Well, that's not that unusual, but it's wide with a little notch. That's what's unusual. And of course, in V6 with left bundle branch block, you see an inverted T wave. So again, not so difficult to understand, not so difficult to diagnose. Okay, so looking at V1 and V6, excuse me, and recognizing that V1, that long strip at the bottom, that's a rhythm strip. So let's not look at the rhythm strip. Look at V1 and V6. Putting your fingers on the paper or your fingers on your screen, V1 and V6. Can you see that in V1 you have a wide, deep downwards? Yes, of course you can. In V6, do you see that you have a big upright and it's wide? Yes, of course you can. And V6 has an inverted T wave. So this patient has left bundle branch block. Okay, very good. I know you got it right. All right, what about this patient? So looking at V1 and looking at V6. Now this for me is an EKG that I wouldn't accept, except maybe we just couldn't get the patient to lay still. I'm looking at V1 and V6. So in V1, I see I have a small r and a second r, meaning current went back to the right and my T wave is inverted. Looking at V6, I see that I have an upright and I don't really have much of a downwards, but I'm not going to use that as my main criteria. I'm going to go back to V1, upright, down, upright again, taking at least 0.12 seconds. T waves inverted. This is a right bundle branch block. Okay, so now let's look at this one, which is almost a repeat of the prior one. Putting your finger at V1 and V6. In V1, you can see you have a small r, a little s, and a second R wave. Back to the right, current to the right. And in V6, you have a small upright and a very big downwards. Okay, so this patient also has right bundle branch block, but he has something else as well, and that would be, not to confuse or muddy your water, I just want to let you know, he also has right ventricular hypertrophy. Okay, right bundle branch block and right ventricular hypertrophy. Wasn't asking you to diagnose that, by the way. Okay, look at V1 and look at V6. Now this is much easier for us because everything's isolated here. V1, double upright, inverted T wave, and in V6, small downward, Q, big R, and then a wide deep S. And in V1, I have an inverted T wave. So what do you call that? Right bundle branch block. Excellent. Okay, looking at this one with your fingers on V1 and V6, recognizing that you have, I think, a V3 rhythm strip, V1 rhythm strip, sorry. So look at V1 and look at V6. Downward and wide in V1, upright and wide in V6 with an inverted T wave. This is a left bundle branch block. So again, one last, or maybe not the last one. This one is a real doozy, right? Because at the bottom you've got two rhythm strips. You have a V1 and a V6 in this one. So take a look at, or maybe it's a lead 1 and a V6. I can't really read what's on the top. Oh, lead 2 and V6 on the rhythm strips. So the last two on the bottom, lead 2 and V6. Okay, so looking at V1 and looking at V6. So don't get confused because you got all those rhythm strips, V1, lead 2, and V6. So just look at V1, just look at V6. V1, deep downwards with an upright T. V6, big upwards, and it's wide with an inverted T wave. This patient has left bundle branch block. He also has something else, and I'm not asking you to diagnose it, but this patient also has left ventricular hypertrophy. So I'm seeing these EKGs, I put them in my program, but I just capture them from somewhere and stick them in there. And I'm like, whoa, that's a really good EKG because that tells you a lot of good information. Now, V1 and V6, I can't even see the top of V6, but I can see that it's upright, and I can see that it's wide, and I can see that the T wave is inverted. And when I go to V1, I can't see the end of V1, but I can see that it's downwards, and I can see that it's wide. This is a left bundle branch block. And when we look at this one, I'm going to let you work it out. So what direction is V1? And what direction is V6? And is the T wave inverted? Okay, and where is it inverted? It's inverted in V6. Now here's the thing on this one, you might not meet that 0.12 criteria. You're at 0.10 or a little greater. We would call this an incomplete bundle branch block. Okay. All right, so there are salient points thus far. Persistent tachycardia is always a warning sign. Pay attention to it. Always investigate for pain, agitation, high fever, and compensatory for tissue hypoxia, which shows itself as metabolic acidosis. That a rapid heart rate limits ventricular filling and therefore ventricular ejection. Persistent tachycardia in a critically ill patient is always a concern for us. We're always going to investigate why that patient has tachycardia. Bradycardia with hypotension is always abnormal. Now you might see that with Precedex, you might see that with hypothermia, but you also see that with a tension pneumothorax or hemothorax. So we want to pay a very particular attention to that. That we have two major groups of electrical cells. We have the pacemaker tree and we have the myocardial branch, the myocardial muscle mass. Primary pacemakers are found, sinus node, AV junction, Purkinje fibers. Non-pacemaker cells, everything but those electrical ones, can depolarize the heart if they are ischemic or if electrolytes are out of balance so that those other cells reach the threshold first. Atrial cells are potassium and calcium dependent for depolarization, and ventricular cells, and please hear me now and listen to me later. I made a typo here. Ventricular cells are potassium and sodium dependent for depolarization. So you see that down below in the key, which is atrial tachydysrhythmias respond to sympathetic control, beta block therapy, potassium and calcium antagonists. Ventricular tachydysrhythmias respond to sodium and potassium channel antagonists. Amiodarone, fixing either one, hopefully, although lots of supraventricular dysrhythmias do not respond to amiodarone. That will be our first drug of choice for those dysrhythmias. Okay, so using your EKG, V1 and 2 have the best view of the right ventricle, and V5 and 6 look at the left ventricle. Choosing V1 for right and V6 for left helps us get a bird's eye view on bundle branch blocks. Look for the RR pattern. Where is your M and where is your W when you're diagnosing or evaluating heart block? With an incomplete bundle branch block, you'll have the morphology criteria, but you are less wide than 0.12 or 120 milliseconds. And hemiblocks, which are beyond what we're going to do in this class, but maybe I'll see you in the future in a 12-lead course where we talk about hemiblocks. That's one of the fascicles of the left bundle. So for right bundle branch block, look for the M in the right-sided leads and a W in the left. And for left bundle branch block, look for a W in the right-sided leads and an M in the left. Thank you so very much for joining me for Cardiac Rhythms. I'll see you next time.